Sure.
Yes. So within a 10 seconds, we will have to the audience platform. Okay. So sir, it's 3, 2, 1. Over to you, sir. Now we are live with the audience platform.
So, very good evening, one and all. Very good evening to my seniors, my peers, and my juniors. Uh, uh, let's all get gathered and ready for an academic feast that is to follow. As you all know from your own individual practice, India is home to 315 million hypertension patients projected as per the ICMR INDIVE 17 study. Furthermore, what's unique to the hypertension in India is there is often metabolic clustering of cardiovascular risk events. Uh, Further, if we delve into the NFHS 5 data uh, and you look at the treatment cascade, only 7.8% of patients have actually achieved control of blood pressure, which is far less than the international rule of halves. Though we agree the NFHS 6 has come, but a further dissection of that data is yet pending. Nevertheless, to manage hypertension in Indian settings, one needs to be abreast with what's uh, latest in the field, and we have the best of experts to guide us in the same. I have the honor of introducing our esteemed moderator and speaker for the day. We have with us none other than Professor Dr. Uday Jadhav himself, who would be the esteemed moderator for the day, who is honorary professor. Next, if you can go to the next slide. Yeah. Who's honorary professor and faculty at MGM University. Uh, the moderator slide, madam. The first slide. Yeah. Honorary professor and faculty, MGM University of Health Sciences, New Bombay, who is also the vice president of the Heart Failure Association of India, the Indian Society of Electrocardiology, and CSI Mumbai, uh, who has 75 publications in peer-reviewed journals across various aspects of cardiology, and is also a research investigator in trials for heart failure, angina, optimal therapy, and cardiac CT radiation. Next, the next slide. Yeah. We also have with us as a esteemed speaker, Dr. George S. Tergio. Uh, Sir is Chairman, STRIDE BP International Organization for Blood Pressure Methodology and Technology. And he's also the president of the International Society of Hypertension. He served as the past chairman of the European Society of Hypertension Working Group on BP monitoring and cardiovascular variability. He's also the WHO independent advisor for blood pressure measuring devices. I now hand over to our esteemed speaker for taking the meeting ahead. Professor George, over to you, sir.
So thank you very much for this invitation. Can you see my slide?
Yes, sir, we can.
And you can hear me well. So thank you for the invitation to present what was discussed in the ESH meeting 2026. This was 2 weeks ago. I attended this meeting. I have to say it was one of the best meetings of the European Society of Hypertension over the last years, and there are several messages which are directly applicable to clinical practice. So you can see here where is Poland, and this is Gdansk. Gdansk is at the north, so they have a very cold weather in winter. But 2 weeks ago, the weather was wonderful. It was sunny. It was really the best time of the year to visit the city. And I have to say that I'm here, down here in the University of Athens in Greece. So this is a meeting with numbers. I want to focus only on the left side of the slide. Almost 30,000 people attended. And you can see here they came from 93 different countries, and there were 112 scientific sessions. Of course, it's not possible for me to present you all these sessions, but certainly I'll try to give you a brief idea on what was very challenging in this meeting and try to give you the atmosphere of the ESH meeting in Gdansk. So the opening ceremony was outstanding because the honorary guest was a former president and he was a Nobel Prize awardee, Lech Walesa. And this was followed by a very unusual lecture by Professor Anna Dominizak from Glasgow, UK. She talked about medicine, science, politics, and politicians, because as you know very well, healthcare is shaped by medicine, but without the politics and the politicians, we can't implement healthcare services in wide scale in our countries. So these are the main lists of topics and sessions on the 3 days. I will, as I said, it's not possible to present you all what was discussed in 3 days, but I'll give you a glimpse of the hot topics in this meeting. I'd like to start with this outstanding lecture by this professor from Denmark that highlighted what was held in the introduction, that despite the huge amount of knowledge and research that we have obtained in the last decade for hypertension, hypertension remains the #1 modifiable risk factor for cardiovascular morbidity and premature death worldwide. In fact, it is the strongest risk factor, not only cardiovascular, for any disease across the world. I'll start with blood pressure assessment because this is my field and it was on the first day. There are lectures about nighttime blood pressure, which is important, blood pressure variability, and devices. Wearable devices were discussed. This has become a very hot issue. Everybody is very keen to use them. There are some handheld devices, and the WHO is more interested on these devices because if we could have a blood pressure application in our smartphone, immediately everybody of us would have an accurate device in his pocket, the smartphone. At the present time, none of these devices seems to be optimal for clinical use, but we discussed in this meeting this kind of devices. These are smartwatch type cuff oscillometric devices, so they have a small inflatable cuff, so they are sophisticated wrist cuff oscillometric devices. They can be used for casual measurement at home or other places, and they can also use for 24 ambulatory monitoring. We still need research on these devices, but these are already available on the market. So moving from cuffless devices, I'd like to show you this industry-sponsored symposium by Skylabs. Actually, I participated in this symposium. This is a ring time cuffless devices. And the reason I want to show you this is because recently the Korean Society of Hypertension recommended the use of validated cuffless devices for 24-hour ambulatory monitoring. And this decision by the Koreans was heavily backed by research on exactly this Korean ring type cuffless device. As I'm discussing about technology, it is interesting to show you this technology. This is a fully implantable system which delivers electric pulses to lower thoracic spinal cord and can be used to people with cardiovascular instability. It showed that in a few patients, it can help rapidly, allowing them to sit, stand, and do what they usually do within some days. So they had results immediately, helping these patients hemodynamically unstable. They had results for 2 years, and now they are expanding research with these devices in 20 centers in different countries, and this might help in other conditions, including Parkinsonism. Let's now move with the drugs, which is always a hot issue in this meeting. This meeting was highly influenced by this poster. This is about aldosterone, highly promoted by AstraZeneca because, as you know, they have their first new drug blocking aldosterone, which is going to be on the market this year. And they actually sponsored 4 lectures by 4 distinguished investigators in this meeting who explained to the audience how these drugs can be useful. So Baxdrostat was presented by Brian Williams in UK. He presented the Bax hypertension and Bax24 study. Actually, it is a very impressive drug in providing a very large, unusually large additional blood pressure reduction in people with resistant hypertension. The drug is FDA registered and is going to be on the market in some regions of the world in the end of this year. So it is something that we start understanding soon be using. And there were in the clinical trials hotline session about aprocitentan. This is a dual endothelin antagonist. This was presented by Bark and Marcus Light in Australia. This drug is already available in several countries for treating resistant hypertension. And this meeting, Professor Slide presented data showing that the drug can reduce albuminuria without influencing the renal function. During the clinical trials hotline, another aldosterone antagonist, synthesized antagonist was presented. This is lorundrostat, but this is a little below in the sex for Baxdrostat. Maybe next year we'll have 2 of these drugs for clinical use. Another very interesting novel drug discussed in this meeting is silebesiran. They presented data as add-on therapy in hypertension in patients with high cardiovascular risk with or without chronic kidney disease. This is a very novel and interesting approach for reducing blood pressure because actually this requires a single injection every 6 months to block the renin-angiotensin system. Of course, this can be used in uncontrolled patients, but it will be attractive even for untreated patients to decide whether they will start taking pills every day or they prefer 1 injection twice per year. But we'll need some time to see this drug appearing on the market for clinical use. Talking about drugs, I'd like to show this interesting poster from your country, looking at the total of evidence we have on telmisartan. It's a very well-known angiotensin receptor blocker. 10 Indian hypertension experts looked at the total of evidence in terms of blood pressure lowering, cardiovascular protection, formulations, bioavailability, pharmacokinetics, comparison with other drugs in the same class, combinations with other drugs, and metabolic and pleiotropic effects resulting in organ protection. I have to say that the contributors, the experts, agreed on their conclusions about this drug, and they showed that beyond blood pressure reduction, this cornerstone ARB provides metabolic precision and pleiotropic ARB protection and flexibility in combination with other drug classes. This is a small study, but an interesting one coming from UK. In this study, they compared amlodipine, clothalidone, and lisinopril in terms of their effects on cardiac structure and function, which is independent of their blood pressure lowering effect. You can see here it's a relatively small study with the 3 drugs, but it is a crossover study, which means that all these 134 patients received all these 3 treatments one after the other. So it's quite powerful study. And they included Blacks, Whites, and Asian people. It is interesting that amlodipine was the stronger drug in reducing blood pressure, but in terms of blood pressure independent effects on cardiac structure and function, troxacidone was the winner and lisinopril was less effective in Black people. And this is the last study I'd like to show you, presented in this meeting about drugs. And this is about people with low diastolic blood pressure who had acute myocardial infarction. You know, the low diastolic blood pressure brings a hemodynamic dilemma to the doctor because we may think that excessive reduction in diastolic blood pressure may compromise coronary blood flow in some of these patients. So it might be a barrier for giving beta blockers and linear transaction system blockers, which are needed post myocardial infarction. So you can see here, this is a Korean registry, the Korea Acute Myocardial Infarction Registry, and they looked at major events for 1 year in almost 12,000 people. The conclusion is that despite all these patients having diastolic blood pressure less than 70, the cardiovascular events were lower in those people who got both drugs, beta blockers and linear angiotensin blockers, were higher in those who took only one and much higher in those who didn't take any of them. So the conclusion is that low diastolic blood pressure should not be a barrier for not giving beta blockers or linear angiotensin system blockers after myocardial infarction, even if diastolic blood pressure is lower than 70. Now let's move to combinations. As you know, antihypertensive therapy is a combination therapy for most of our patients. And this is a classic study which looked again from Korea. Actually, this is analysis from 2 randomized control studies from Korea and looked at telmisartan combined in a drug, a pill with S-amlodipine, the S isomer, the active part of amlodipine, with similar action with the lower doses. And you can see they start with telmisartan 20 and S-amlodipine 1.25. And you can see they saw that the combination, of course, is more effective than the single therapies. And the conclusion is that this low dose combination is superior than the monotherapies and have a favorable safety profile, which means that we should start using them early rather than late in the management of hypertension. But I think the most exciting study in this meeting about combination was the optimal study. This is a study from the George University in Australia. In this case, they used triple single pill therapy, but with very low doses. The concept here is that you may start the treatment with 3 drugs if they are in very low doses. The question is it safe? Is it effective? So they used a single pill with telmisartan, amlodipine, and indapamide, but look at the doses. Telmisartan only 10, amlodipine only 1.25, and indapamine only 0.625 to start treatment in untreated patients. Then in those 2, they double the dose, and then they do 4 times this dose. So they showed that starting with 3 drugs altogether in low doses does not increase orthostatic or symptomatic hypertension compared to starting with 2 drugs or placebo. So here we have a new concept, whether from step 1, we can start with 1 drug, with 2 drugs, but also with 3 drugs, provided that they are in very low doses as used in this study. I'd like also to show you that there were 2 sessions on quadruple therapy, 1 pill, 4 drugs, 1 session here and another here. These sessions were sponsored by Servier because, as you know, Servier has this combination perindopril, indapamide, and amlodipine and bisoprolol, which is a quite useful drug when you are treating resistant hypertension and you want to simplify therapy. And it's not only this four-drug combination, there is another one, the quarter study with irbesartan, amlodipine, indapamide, and bisoprolol. So you might start considering how to simplify therapy in those patients with difficult hypertension who require more than 3 drugs. So you can give 4 drugs in a single pill. Another topic discussed here in this meeting was adherence. Adherence is a major problem all over the world. We prescribe the drugs, but many patients stop taking them or don't take them regularly. And if you are not taking your pills regularly, you are not protected. So non-adherence is a risk factor because non-treating a risk factor is a risk factor by itself. Also, there was a session here chaired by Professor Bournier from Switzerland and Professor Gupta from UK, and both of them are very highly interested in adherence. And they looked at how we can use new tools to improve adherence. We can use artificial intelligence, we can use digital tools, and you can use education of patients. And these tools have been shown to work in improving significantly adherence. I'd like to show you also one poster which looked in new patients about non-adherence, and they assessed the adherence at baseline, after 1 month, and after 4 months. And they confirmed the problems we have, that even in the context of a clinical trial, many patients do not adhere right from the start. You lose more patients at 1 month and even more at 4 months. It is something which is a headache for all of us, I'm sure also in your country, and we need to work how to improve it. Now, I'd like to start presenting you some data from special populations. There were sessions about women, about hypertension in pregnancy, about pediatric hypertension, and also about hypertension in the very old people. So hypertension in women is a challenge. Hypertension in pregnancy is becoming a serious problem. We now have a new definition of hypertension in preeclampsia, and we are not allowed to lose today any woman because of high blood pressure. And what is new in this field and was widely discussed in this meeting is that hypertension in pregnancy brings important messages for the woman and the baby for the future. Women who have hypertension in the pregnancy, they have higher risk for chronic hypertension, higher risk of cardiovascular disease in the future, for heart failure, for renal disease. So one thing is that we have to warn these women that after pregnancy, they have higher cardiovascular and hypertension and renal risk and should be followed. And here you can see recommendations how to follow women, even if after the pregnancy, blood pressure is fine, because they still have future risk for hypertension and cardiovascular and renal disease. Childhood hypertension, I think this was an important session because we know that pediatric hypertension is often left untreated. Because doctors may think these are young kids, they will not be harmed by hypertension. And this session clearly showed that today, hypertension, which is often coupled with obesity, causes damage in the young children, causes vascular changes, causes cardiac target organ damage, and causes renal damage. So we are never going to see cardiovascular disease in children and adolescents, but preclinical damage is very important in the young population, and we have to find tools to assess it, prevent it, or regress it. The last special population, is the population of the very old people. This was a session which was joined by the European Society of Hypertension and the European Geriatric Medicine Society. So the main point in this discussion was that age by itself is not a barrier, but frailty is the most important aspect for guiding treatment decision in old people. And it was a very interesting debate. One speaker from Sweden saying that the systolic blood pressure target should be higher than 130, very aggressive, similar to the American recommendations, and another speaker from Netherlands who are a little more conservative. I don't know what is your opinion about how to select these very healthy elderly people who need aggressive treatment, but certainly this is something we should be looking at, and we should not leave elderly people uncontrolled if they are in very good physical and mental condition. And there are several other topics, and I'll just pick some of them to show you. There were several sessions about GLP-1 in medicine and cardiovascular protection. There was an amazing lecture by Professor Knudsen. She described the journey of GLP-1 inhibitors, how they started as a glucose-lowering pill, and they became a kidney and cardiovascular protecting actually a major cardiovascular drug. And I'd like to show you, this is Professor Knudsen from Denmark. I think it's very important to see her main conclusions. The first conclusion was that the full potential of these drugs is likely only beginning to unfold. The second is that for all of us who work in hypertension and cardiovascular medicine, the implications for the knowledge we have now for the ability of the drugs to prevent cardiovascular disease, renal disease, reduce blood pressure, improve metabolic factors is significant. And she concluded that using GLP-1 receptors is about recognizing what the biology of the cardiometabolic disease actually requires. It's a central drug affecting so many aspects of the cardiometabolic problem we now face in our patients. I think you know very well the MMM's project. The MMM, May Measurement Month, was a project initiated by the International Society of Hypertension. It is running every year in more than 100 countries, and we measure about 1 million people every year. Last year, I think we measured 800,000 people, and I'm sure this happens also in India. And in this meeting, Professor Neil Poulter presented the lessons we got from the MMN on how global opportunistic blood pressure screening can help identifying those people who have hypertension and do not reach the healthcare and remain uncontrolled, and of course, those who take pills but still do not have optimal blood pressure control. There was another interesting session, which I think is interesting for you, is we discussed how to deal with hypertension when you do not have enough resources. This is not about high income and low income countries. It is about low resources, because even in rich countries, let's say in the United States, there are places with low resources. And in very poor countries, let's say in Africa, there are places with high resources. So wherever you are, if you have low resources, there are still things you can do to be effective. And this is something that also the WHO is looking at, how to deal with hypertension with the essential tools when you don't have all what you want to do. Now, coming close to the end, this was a joint session by the European Society of Hypertension and the International Society of Hypertension, chaired by the two presidents, Professor Janušević and myself. And here we discussed what do we have today to improve hypertension control. We talked about patients' education, which is essential. We talked about including healthcare professionals which are not doctors. In all countries, even in India, doctors cannot control hypertension in the population until we will engage non-doctor healthcare professionals, pharmacists, nurses, medical assistants, and of course, technology can help. So coming to the end, in this meeting, we actually discussed how artificial intelligence is changing medicine in front of our eyes with smarter tools and better care. We discussed how information can help and bring responsibility, and how genomics can improve individualized risk to precision prevention. And for all of this, we need validation, equity, ethical framework, responsibility, and in the center, the human judgment. So the future of cardiovascular care is not going to be defined by technology alone, but our ability to integrate AI, genomics, and digital communication, all these new tools we have, into an ethical, evidence-based, and patient-centered practice. So, dear colleagues, it was really a very successful meeting. These are my own photographs I took there. I took in Gdansk 2 weeks ago. You can see how nice weather and how beautiful city it is. This is a photograph from the presidential dinner in a wonderful museum in Gdansk. And you can see here the president of the meeting, Professor Nakiewicz, and the president of the European Society of Hypertension, Professor Janušević. You can see how happy they are with a very successful meeting. And thank you very much for giving me the information to review this really successful meeting and present it to you.
Thank you, sirs. I now invite Professor Dr. Uday Jadhav, sir, for conducting the panel discussion with you and ultimately taking the audience questions. Professor Jadhav, over to you, sir.
Professor Dr. George, this has been a very fascinating review. Amongst the many meetings that I attend for hypertension, after a international meeting, this is probably one of the best in terms of the way you gave us the highlights, very comprehensive and yet very pointed, very focused in terms of the clinical messages. So this is great. I thought that there were a lot of new things we learned today. I also looked at some of the questions. So let me start with what you discuss and what we think is relevant to clinical practice. Let me start with the first aspect that with the emergence of AI and the gadgets which are used to measure the blood pressure, the digital gadgets and the watches were not very well favored in the guidelines, particularly the US guidelines. I think European guidelines are much more pro. Do you see a change for the digital appliances to measure blood pressure? Because that would become a way forward of home blood pressure monitoring also, and could probably reduce the variability that we see among the various gadgets. Your comments on this, sir?
So that is a very interesting question, and actually I could give you a lecture about this, but it's a quite complex issue because I'm working on that. There is no question that cuffless blood pressure measurement is amazing. Having a wearable device measuring blood pressure all the time, at home, at work, at day and night for a week, is what every doctor would like to see, because here we have all the blood pressure information. So when we get it right, we're going to forget whatever we do. We don't need office home ambulatory. The problem is that at the present time, none of the cuffless technologies had shown convincing evidence that not only that it can replace, but also that can even help in any way. So it's not only the American Heart Association, the European Society of Hypertension, and the European Society of Cardiology, all of them do not recommend cuffless devices. But technology and medical engineering has changed medicine. I hope that at some time they'll come up with something new. Not PPG. The current technology we use is not enough for clinical practice. So we still wait for medical engineers who changed medicine, made it so technology-based to give us something new, and then certainly this is going to be valuable.
Well, the other aspects that came up through your talk and the recent presentations at ESH is how do we deal with patients who have a little difficulty to control hypertension with the utility of all the standard medications in combination at the optimized doses. I'm saying that because only the optimized doses have been shown to reduce the major adverse cardiac events and the endpoints and end organ damage. So when we looked at those medications, I think the first one which you highlighted has been Baxdrostat, and it's making its inroads in India too. One of the aspects that I looked at Baxdrostat is that one, it's expensive as of now, but when it comes to it reduces the USCR, that's the advantage. And the Bax hypertension 24 hours ABP data, ambulatory blood pressure data is very, very good, very robust. But then, if you look at what you can add to the conventional treatment was spironolactone, let's say in some of this earlier studies, pathway, for example. And if you purely compare head to head between Baxdrostat and spironolactone, which is very cheap, in fact, there isn't much of a blood pressure reduction. They're comparatively the same. It's only the USCR that makes a difference. So that's one observation for Baxdrostat. Uh, Second is, of course, then how would it differ from lorindrostat? Both have good clinical data. And then the third is at least in India, that's what we try and look at. I know it's not a label use, but we use it very extensively, believe me, is sacubitril valsartan as a single dose following the Japanese guidelines and the Chinese experience and some of the European experience also. That sacubitril valsartan is a great drug as a neprilysin inhibition add-on to reduce the blood pressure and difficult to control. Your comments on this before we go to Zilbisara.
Well, Professor, this is another lecture I have to give here. It's really a hot topic. These people whom we can't control with our drugs. First, we have to check adherence. We shouldn't forget that. Many of these patients have apparent resistant hypertension, not true resistant hypertension. So first, we have to prove that they really have uncontrolled hypertension. They do take their drugs, and blood pressure is confirmed and controlled. And if we do that, half of them are going to show not to have true resistant hypertension. But there are many patients who need something more than the three drugs. All the guidelines agree that the next step after the three drugs, RAS blocker, CCB, and diuretic, is spironolactone. Why? Because they know that aldosterone is the key driving mechanism in these patients, driving uncontrolled blood pressure. And this is why Baxdrostat was so impressive. So you mentioned spironolactone versus baxdrostat. It's a very challenging issue. We don't know exactly how different they are because we don't have a direct comparison. But I suspect that baxdrostat is slightly safer drug, and maybe both of them give this profound blood pressure lowering effect. There is no other drug than these two which will give you such a visible, in one patient, blood pressure lowering effect after giving the drugs. So we have to see, we have to obtain more experience with baxdrostat because you know very well that family doctors do not use spironolactone. And this is the right thing because to use spironolactone, first, you have to make sure that potassium is okay, GFR is okay, you don't have gynecomastia, and also you have to make sure that the patients will come back with a blood test. If the patient is not going to have a blood test after a few weeks, you shouldn't give spironolactone. And all of us who give it, all of us have seen potassium 6. All of us have done that. So I hope that baxdrostat will prove a little safer. No question is going to increase potassium. We have seen that already, but maybe it's a little safer, and certainly it doesn't have gynecomastia. So
Uh,
I think if you can give spironolactone in terms of finances all over the place, you should use it. But many people will not take it.
well, in continuation, that brings to another point, which is getting popular, is that finerenone is a pretty good drug in terms of hypertensives who have LVH and potential candidates for HFpEF. Now, we have tremendous data with finerenone from all the clinical trials, and the USCR reduction is as good as baxdrostat. And it will work for reducing the blood pressure also. So here is another great molecule. Why wouldn't one think of finerenone just like we think of eplerenone and spironolactone with better evidence, with more robust data over the last 3-4 years? What do you think?
No question, it is a cardiovascular drug, which is the first property for a drug should be a cardiovascular protective drug, and finerenone is one of them. And it should be because it works in a mechanism we know that's important. I think we haven't seen good data focused in hypertension because the research has been focused. But you are right that I would expect very good data also with these drugs. Again, with the same problems with spironolactone and the baxdrostat, we don't know exactly the differences, but certainly a very good cardiovascular option requiring more focus of research in hypertension.
Also, let me blend two questions here together. That I was chairing a meeting last week with Brian Williams, and the zilebesiran data. I guess the Zenith study is still on, and maybe 2030 will get a data on 5,000 patients whether there is an event reduction, and therefore that's exciting beyond the cardia 1, 2, and 3, where the zilebesiran will make a difference. But I wanted to have an understanding from you that I've been listening to these low dose combinations which have come through in Australia. There are some clinical trials for blood pressure reduction in India too, with low dose of uh, triple or four drug combinations. But will that translate into event reduction? Because the existing thought process is you give a optimized good dose of combinations of proved therapies like ARBs, telmisartan, CCBs, amlodipine or selnidipine. You may probably get better event reduction. So should one, just for the sake of tolerance, getting less hypotension, better adherence, should one stick to lower dose combinations, or it's better to go with conventional optimized doses?
That's a very interesting topic we all have to think about because it's here, it's being discussed. So one point we have to remember is we don't have outcome studies with very low doses. We don't. We assume that they are going to be good, but we don't have this data. Second, I would be very happy to prefer low doses with all drugs, with one exception, RAS blockers. And if you have hypertension, that's fine. But if you have organ damage, renal disease, cardiac damage, then I don't want to see RAS blockers in low doses. I will exhaust the full dose of RAS blockers and then maybe consider that. So when you have a compelling indication, you have many patients have, you are a cardiologist, many of your patients, you wouldn't give RAS blocker in low dose. You want to, and sometimes you need to give diuretic in full doses. So if you have hypertension complicated without organ damage, that's fine to discuss that because you are looking at blood pressure lowering drugs. But if you have cardiovascular indication, RAS blockers particularly should go for the high dose.
George, absolutely. I really thank you for that message because I mean, we really don't see many patients in India without some level of target organ damage or some level of absence of comorbidity. So the whole idea is to prevent events and target organ damage rather than just looking at the blood pressure number. So that's very important observation you had for us today. Um, there was a question on the chat box that if you have reviewed the now entire ESH meeting and your experience, can you identify potential candidates for renal denervation therapies? What will be your recommendations?
Well, to be honest, we have two groups of experts here. Those who do renal denervation and those who don't do. Those who do, they're aggressive, they want to do it as much as possible. Those who don't are more skeptical. I think both sides are wrong. We shouldn't underuse and we shouldn't overuse. So renal denervation is here. We have many systems. It is available in many countries. We must find a way of using that. So, in my opinion, if you have a patient and you cannot control blood pressure using the 4 lines we discussed already in the previous questions, if you use the 3-4 drugs and you play with spironolactone and blood pressure is not controlled because you need more drugs or because you can't take some of these drugs, I think you should refer this patient for renal denervation. If you properly use these drugs, these cases are few, but we have these cases and we should try renal denervation. It's here, we must find the patients to use them. Using them too often is not good, not using them is wrong.
Well, there's this other whole controversy in India about beta blockers, and beta blockers are very popular in India, by the way, for whatever reasons for hypertension. And we always had a little flip-flop on the recommendation. I mean, the US has never been very supportive, or rather, they have not been supportive for beta blockers at all, unless there is a compelling indication. And I was a part of the reviewer for the ESC 2023 ESH guidelines, and 23 they did recommend beta blocker as European Society as one of the class of medications you can consider for that. And then 2024 again downtoned it, saying that probably you should still look at comorbidities. What is your take home on beta blockers? How should it be used in the therapy of hypertension, either as a monotherapy or in combination?
Well, Professor, I know that I'm talking to a cardiologist and I'm careful. I know you love these drugs, and not only that, many of your patients must take this pill and in as much as possible because they live longer. So beta blockers, everybody agrees they are very powerful drugs in when you have these compelling indications. But we doctors know that there are many other patients in whom beta blockers are useful. There are many patients who feel better with beta blockers. There are patients where you want somewhat to control heart rate. It's not that they have atrial fibrillation or something like that, but they need a kind of blood pressure control. So it's not my first thought for treating hypertension, but many of our patients have compelling indications and many have soft indications and they benefit and they feel better for using them. So I'm somewhere between. I think we have to use them. We need them very often, and they are very helpful, particularly in young people, even when they don't have these hard, compelling indications.
Thank you. Dr. Parthasarthi, if you are there, do you see some questions on the chat box, or do you wish to propose some questions as we are almost near the end of our web meeting?
So, so the questions are the same that we put forth to the chat box. If you could just give me a minute more, I could scan again, a very quick scan through. So there's one interesting question which asks that in guidelines, ARBs plus CCBs, a combination of ARBs with CCBs, are placed along with a combination of ARBs plus diuretics. Guidelines have not stratified patient populations for the two. So are there any specific subsets in clinical practice where one patient population might benefit one over the other? We do understand CCBs also have anti-anginal roles and so on and so forth, but any specific takeaways to both of you, sir, Professor Uday Jadhav and Professor George?
Let's start with Dr. George first.
Well, I have to remind you that I am a president of the International Society of Hypertension, and the recommendation by this organization is start with RAS blocker and CCB. According to the International Society of Hypertension, diuretic is the third drug. So if you don't have any compelling indication, you should prefer the CCB. Remember the ACCOMPLISH study. Many people say it is one study, but 12,000 people, randomized control. You can't ask for another study like that. It's a huge study, a huge investment. Second, if you have any indication of edema, your patients, we have these old people, not of heart failure, because this is obvious. We are getting to the heart failure chapter. But if you have these people who get breathless, they have swelling in the ankles, they do better with diuretic, and many elderly do. But if you don't have any special reason to prefer the diuretic, I am in favor of CCB as together as blocker. Of course, if you can't tolerate high dose or you're not controlled, then diuretic is a must as a third drug. But for most patients, I'll first consider CCB as a second drug. And if I have a reason, and there are several patients and many diabetics, they'll do better with a second drug as diuretic. So this is official. We have received criticism about that, but we insist on our position. And I think many doctors prefer this recommendation. This is what they actually do.
I'm
Professor
very
Uday?
glad, George, you said it so very categorically. It's so very important. I mean, we had accomplished study, but let's come that uh, by choice, it has to be a ARB and CCB because everything that matters in terms of the event reduction is a combination of ARB and CCB. Unless there's some evidence of cardiac failure, then of course your uh, diuretic therapy would get a little more promotion. And not that the pedal edema induced by amlodipine really should be occur. It's pretty innocuous side effect. There's nothing there that should make one very worried. It's about how we have our dialogue with the patient and how we interact with them and make sure that, but CCB are phenomenal class of drug. So absolutely, I think ARB CCBs at an optimized dose probably would be the most protective amongst whatever we combine for blood pressure lowering. Yes, Dr. Pathasarthi.
So we also have the last question for the day, which is again on beta blockers. So Professor George mentioned in one of his slides a very beautiful study for the role of beta blockers post MI. So there is one interesting question in the chat box which asks about the role of beta blockers post MI In light of the current data, the reboot CNIC and the ABIS data, especially in patients with preserved ejection fraction. Your take on the same, dear sir, Professor George and Professor Uday sir.
Yeah, I think the question refers to this discussion that you don't need to use long-term beta blocker therapy after some time. I think if the patient is his heart is healthy, it seems that we cannot prove an advantage of keeping beta blockers on board. Of course, there is no damage. So I think after some time with a healthy heart, and there are several people who have a healthy heart after an event because they were managed very fast. So you can decide if you need to keep a beta blocker or not, but you can keep it, of course, but you can take it off. This is the message. But I think it's not a major issue, and it's not mandatory. It's not a damage to keep this drug on board, but it's not clear benefit. That's what we knew from this data, that in these patients who don't fall in the category of reduced ejection fraction, you don't have a benefit. But I don't think that as a major issue, you can keep it on or off without problem. I'm sure cardiologists would prefer to keep it on.
Yeah, I mean, FPEF is a little different ballgame. We don't have an approval for beta blockers specific to heart failure because lowering the uh, heart rate at that point of time may worsen the exercise tolerance, and we don't have great data about it. So it's not in one of the pillars of FPEF therapy. But my contention is always this, that what are you dealing with? Are you dealing with patients whom you have identified very early getting into HFpEF or are potentials for HFpEF, whatever controls the blood pressure? That's the way to go forward with it. Once you have a HFpEF, then probably you would not be great mm, with beta blocker. For that matter, once patients get a HFpEF, then you may have to look at therapies which are now recommended for HFpEF and whether they can reduce the blood pressure. I mean, there is a potential, as Professor George explained, you have GLP-RA1s which may be great for HFpEF, not necessarily for HFrEF. But for HFpEF, they may be great candidates. Finerenone can be a great candidate there. So things which can reduce the blood pressure there are very helpful. And that's where we feel that large thick ventricles and left atrial pressure just going up. The early use of sacubitril valsartan at that point of time in difficult to control hypertension may be a way forward. But these are more observations when we treat patients on day-to-day basis and get those evidences. Thank you.
And I'd like to add to this that this patient who took beta blocker for a cardiovascular indication, even if his heart is fine, he's a very high risk patient. So I would probably favor to keep the beta blocker. It's still very high risk patient. He had an event. We can't say he's fine, he's perfectly okay, because the measurements they got fine. There are still very high risk patients. I'll probably sleep better if I have the beta blocker on board.
Beta blocker, absolutely. And irrespective of the heart failure, it's absolutely necessary to rule out underlying ischemia and coronary artery disease because both HFrEF and it's not that all HFpEFs are infiltrative diseases. You can still have ischemia. So any evidence of coronary ischemia and beta blockers are absolutely on. They are absolutely required medications. Yes, agreed, sir.
So what actually you're saying for this patient who is now doing very well, he's doing very well with the beta blocker. If you take out the beta blocker, maybe for many patients, not a good idea. I know that I've seen that with these discussions about beta blocker, many doctors withdrew beta blockers and had to put them back again. It happened.
Absolutely. I think our faith in India in beta blocker is still justified. I wouldn't at all remove it from the entire therapeutic armamentarium. It's an important medicine, and we must give it the importance that it always had over so many decades. I mean, it's a very established therapy. Thank you. Yeah, Dr. Parthasarathi, we are at the end of the meeting, so
Sir.
maybe.
Thank you so much, Professor George and Professor Uday sir. Uh, it was a very enthralling meeting. A lot of points in hypertension discussed in a very short point with clear takeaways. Professor George, we take this opportunity to thank you. We've had a very engaging audience. In India, it's actually in the night I mean, it's almost 9:30 in the night. So at this point of time, having such an engaging audience, it's purely because of the talk and the discussion. Uh, Also, what the audience has appreciated in the comment section is the fact that it was not just discussion of data, but clinical implications for the same in clinical practice. Uh, Professor Uday Jadhav sir, uh, again, an excellent moderation from your end. Uh, if I might use an Hindi word for a lack of a great substitute in any other language, a great manthan, a fantastic admixture of uh, clinical evidence and relevance to the Indian perspective, which is something that the audience has deeply appreciated. The audience, we thank each and every one of you too for taking your valuable time right now and being part of this discussion, because ultimately we're very sure that the insights discussed here with would help you with your uh, patient care and ultimately improvise on patient care outcomes. Last but not the least, we also thank Imagica Health, our valuable technical partners, for uh, wonderfully aiding us in hosting this wonderful webinar. Thank you so much, Professor George and Professor Uday sir. Thank you.
Thank you. Thank you very much. It's an
Thank
honor
you
to
for
have Professor
having
Dr.
me.
George with us today. Yep, it's really
I
honor
hope
to
it
have Professor
was
Dr. George with us today.
I hope it was useful, and thank you, Mr.
Yes,
Chairman, for simulating a very interesting discussion for me as well. Thank you very much.
thank you.
Thank you, sir.
Well, yeah. Thank you so much, everyone. So from here, I'm closing this meeting. Thank you.